Hello, everyone, and welcome to this week's edition of Chat Night Africa. Chat Night Africa this week, emergency broadcast. In just a moment, you will understand why. Chat Night Africa live from Washington, D.C. metropolitan area. On Chat Night Africa today, production advisor Dr. B. Tatsong Famunda. Broadcast director Mombalingwa. Social media platforms manager and video editor Roger Full. Studio manager Beatrice Formunen. This is Chat Night. Production assistants John Tanto, Emmanuel Wayindi, and Lord Benson. This is Chat Night Africa from Washington, D.C. metropolitan area. On Chat Night Africa today, you will be having as guests Dr. Kenneth Former Mono. Please join me in welcoming Dr. Kenneth Former. This is Chat Night Africa from Washington, D.C. metropolitan area. Chat Night Africa Live is compiled and presented by Divine Chamukong. Chat Night, the power of Chat Night. We're gonna dance. We're gonna dance. We're gonna dance. We're gonna get down. We're gonna get down. Hello, hello, hello. Welcome to this edition of Chat Night Africa. Anytime someone, especially a loved one, is diagnosed with pancreatic cancer, it feels like thunderbolt. Is pancreatic cancer a death sentence when you are diagnosed with it? What exposes you to pancreatic cancer? These questions and more on the show today. And ladies and gentlemen, join me in welcoming the doctor who will be taking your questions on pancreatic cancer. The man you see on the screen is Dr. Kenneth Former Mono. Welcome, Doctor, to Chat Night Africa one more time.
Oh, thank you very much, Divine. Thanks.
Who is Dr. Mono?
So, I am a trained medical physician from Cameroon, did my medical studies back in Cameroon in the Faculty of Medicine and Biomedical Sciences. And also, I am a public health physician and a clinical pathologist trained, and also an internist in the US who is specializing in cancers and hematological diseases.
This is Chat Night Africa, and as you must have realized, the person who is on the screen now on the platform will be taking questions. And when it is time for him to take questions, I will let you know. Now, I have a series of questions for you on the show today, Doctor. The first one is pancreatic cancer attacks the pancreas, but what exposes people to the cancerous attack?
So, pancreatic cancer is one of the most devastating cancers. I would like to start by telling the people exactly what the pancreas is. So, the pancreas is actually an organ which you have in the body, which is responsible for helping us digest certain foods. It produces certain enzymes that help us in digestion. Those are things we call the exocrine function of the pancreas. The pancreas is also very responsible for helping us regulate our blood sugar, and it produces certain hormones in the body. So it's a very important organ that we need in order to help us do a lot of metabolic regulations, help us control the amount of sugar in our body, and also help us digest food. Now, it's among other cancers, there are very clear risk factors. But for the pancreatic cancer, they are not as clear as other cancers you would want to talk about, like lung cancer, we do know risk factors. For pancreatic cancer, smoking can increase your risk of getting pancreatic cancer. It doesn't mean smoking causes pancreatic cancer. Also, obesity increases your risk of getting pancreatic cancer. And at times, the kind of diet you eat, increase red meat may also help you, or may also expose you to getting pancreatic cancer. Diseases like diabetes also increases your chances. Those who are diabetic, those who have chronic pancreatitis, meaning inflammation of the pancreas over a long period of time, and also those who have liver cirrhosis, meaning your liver has been destroyed by several things, including alcohol. So indirectly, alcohol is also a risk factor for pancreatic cancer. Those are things we can modify. So we call those, all what I just said, are modifiable risk factors for pancreatic cancer. You do have non-modifiable risk factors that can actually make you have pancreatic cancer. Some people do have family history of cancers, including pancreatic cancer. There is a gene called the BRCA2 that can also, you can have that in your family and get to have pancreatic cancer. There are other genes, I'm not going to cite them here. There is a PALB2 gene, and there are other genes that are responsible for increasing your chances. I'm using that word very well. You do have being above 65 is also a risk factor for getting pancreatic cancer. And being an African American also increases your chances. So those are some of the risk factors I can tell you about. Some of them are modifiable, others are non-modifiable. So I think that's what I can say for now.
Dr. Former, is it accurate to describe pancreatic cancer as one of the deadliest of cancers? If yes, why?
So the thing about pancreatic cancer is that we do diagnose it pretty very late. And it's one of those cancers that once you have it, it's usually silent. So it's more of a silent killer. A lot of people don't even know they have pancreatic cancer. So the time it's being diagnosed is diagnosed when it's stage 4. I will later on tell you what stage 4 is, meaning it has gone to other organs. We use the word metastasis to other organs. So that's really one of the reasons why pancreatic cancer is so deadly. And also, the pancreas has like a hard tissue around it called the stroma. We do have issues with chemotherapy. That's drugs we use in order to kill cancer cells to penetrate and get into the cancer itself. So the overall survival for pancreatic cancer, if someone is diagnosed with pancreatic cancer, taking all the stages together, in the next 1 year will be about 20%, which is an improvement from back in the 70s. And the 5-year survival rate of pancreatic cancer is about 7%. So those who have it, once you diagnose them in 5 years, just 7% of them are going to be alive. So it's really one of the deadliest cancers we have, but there are improvements going on in the world of medicine in order to help treat those who have it. And it really depends on what stage you find yourself.
Doctors like you say that there isn't only one type of pancreatic cancer. Is that correct? If yes, which are the other ones? Because we know that pancreatic cancer is pancreatic cancer. How does one differentiate? How is one different from the other?
So overall, cancers are named over the organ which they affect. Like if a cancer affects the lung, we call it lung cancer. If a cancer affects the breast, we call it breast cancer. But there are different histological tissues that the cancers have their origin from. And that is also going to tell us about how the patient is going to do, the prognostic factor of the patient. So for pancreatic cancer, you do have 90% of them are what you call adenocarcinomas, meaning they originate from glands. You do have neuroendocrine tumors that also get their origin from the pancreas, from the cells I told you that produce hormones. And also you have certain cells in the pancreas which are ductal cells that can also get cancers, and cystic cells which are called cystic adenocarcinomas. So there are really a variety, and the pathologist usually helps us in telling us exactly what kind of cancer you have so that we can be able to treat you. Majority of the time when you hear about pancreatic cancer, it's usually the adenocarcinoma. So it's originating from gland cells which are found in the pancreas.
This is Chat Night Africa, and my guest today is Dr. Kenneth Former Muno. Chat Night, the power of Chat Night. Walk me through stage one through stage, from stage one through stage 4. How do you begin to know that you have pancreatic cancer?
So majority of the time it's found incidentally for those who get their cancers actually diagnosed early. And for pancreatic cancer, most of the time someone does an exam called an imaging exam of the stomach and also of the pelvic area, and they find like a tumor. They find a gland which is something which is not supposed to be there. And what they would do is they'll get to biopsy it. So when we talk about staging of a cancer, it's actually helping us to know exactly how how big the cancer is and the organs the cancer has gone to. So for pancreatic cancer, talking about the stages, you have, for most cancers, you have stage 1 up to stage 4. Pancreatic cancer, stage 1 of pancreatic cancer means the cancer is actually less than 2 centimeters. And once the cancer is above 2 centimeters but has not gone into neighboring organs, we do call it stage 2. Once the cancer goes into other organs that are around the pancreas, including the bile duct and also including certain structures around that area, we do call it stage 3. If the cancer goes all over the body, metastasis to other organs in the body, that is when we call it stage 4. And the prognosis of the disease really depends on the stage for all cancers. There is also something we call the grade, which pathologists do look at the cancer and tell you exactly how the cells look like. If the cells actually look like the original cells that have that occupy the tissue, or they look like some cells which are really replicating very fast. So all of these things do matter exactly when you're treating cancers.
This is Chat Night Africa, and we're broadcasting from Washington, D.C. metropolitan area. Most times, Dr. Former, people with pancreatic cancers, when they're diagnosed, it's like a thunderbolt, as I said in the beginning. And that's probably because it's gotten to a stage that you can do anything about it. Are you able, you doctors, are you able to treat, at what stage is pancreatic cancer treatable?
So, talking about in medicine, there are times we can actually cure the disease. There are times we can give you medications to keep you alive. So, once pancreatic cancer is diagnosed, it's a multidisciplinary team that works in order to look for the best medication for you. Usually, you have the gastroenterologist, which we work with closely. You have the medical oncologist, which that's what I am training in. And you do have the radio oncologist, and you also have the radiologist and the surgeon. So for pancreatic cancer, the early stages of pancreatic cancer, the main doctor in this stage is usually the surgeon. Once the cancer is still located in the pancreas and has not affected neighboring organs, we can do surgery in order to take away the tumor and make sure the neighboring organs are not affected. And we either do radiation or chemotherapy before the surgery, or we do it after the surgery. When we do that before the surgery, it's something we call neoadjuvant treatment. And once we do it after the surgery, it's called adjuvant treatment. But in early stages, pancreatic cancer can actually be resected. And surgeons do several procedures, including what we call the Whipple's procedure, which is done by certain surgeons. And depending on the location of the pancreas, if the tumor is found at the tail, they can just take out the tail of the pancreas and the body of the pancreas and also take out the spleen. If the tumor is found at the head of the pancreas, that's when they do the Whipple procedure. There are times they can take out the whole pancreas itself. So those are the things which we do for early stage cancers, especially for early stage pancreatic cancers, and that is when it's curable. That's when it can be cured. Now, if you come in with a disease which is pretty advanced and you are not a candidate for surgery, what we do is we do look at you in a multidisciplinary approach, and the oncologist usually proposes chemotherapy, especially if your functional status is good, meaning you're able to move around and do the activities that everyone does. And we work hand in glove with radio oncologists that will provide some radiation to the area. And we do also have some fancy therapies which have not worked very well in pancreatic cancer, which clinical trials are going on these particular forms of therapy. They are called immunotherapy. We use the immune system itself to kill cancers. And there is also what we call targeted therapy, which we have used in a lot of other cancers, like cancers of the lung, including non-small cell cancer of the lung and small cell cancer of the lung. But they have not shown a lot of promising results in pancreatic cancer. But there's a lot of research going on in pancreatic cancer to see exactly how these specific agents are going to do on these specific drugs.
When you see somebody suffering from pancreatic cancer, you almost can tell. And the first indication is how emaciated the person is. What takes away, what eats up somebody's flesh when he or she has pancreatic cancer?
So generally, once you have cancers, what happens is most people lose appetite, and they get anorexic, meaning they do not have any appetite to eat food, so they lose weight. There is also the cancer cells are highly metabolic cells, so they consume a lot of energy in themselves. But for pancreatic cancer as a whole, the pancreas actually helps in digestion, as I told you, and it produces digestive enzymes. So with the lack of production of these digestive enzymes, you get not to digest food in itself. A lot of patients with pancreatic cancers have nausea and vomiting, so they vomit all the time. Those are some of the symptoms and signs you get once you have pancreatic cancer. They also have a lot of pain, and at times, once they eat, the pain gets worse. So they are afraid to eat in itself. So it's a multifactorial reason why they lose weight. They have abdominal pain, they have epigastric pain, they also have what you call steatorrhea, meaning their stool is fatty and they are unable to actually digest food appropriately. So these are some of the reasons why you get a lot of patients with pancreatic cancer lose a lot of weight.
What causes the pain? Because, I mean, people with cancers suffer a lot of pain. And I'm talking about excruciating pain. Why is that so?
It all depends on which of the cancers. So in itself, the cancer is growing and it does affect neighboring tissues. And in pancreatic cancer as a whole, there is also the compression of the cancer to neighboring tissues, inflammation around that area causing pain. And in order to help with their pain, we have to put them on a lot of medications, which are medications we're afraid of right now. These are morphine. They have to be on it. Certain surgeries can also help. But the pain itself comes as a result of inflammation, as a result of expansion of the cancer itself, as a result of expansion of the trauma. That's the coating of the tissue where the cancer is located in.
Why doesn't pancreatic cancer stay in the pancreas?
Sorry, I didn't get your question well.
Does it spread to other areas of the body? And if yes, why so?
Yes, so tumors generally spread to other areas of the body because cancer cells in themselves do not actually attach. They get the turn to detach themselves from the organ where they are formed originally. And they can spread through blood or through what we call the lymphatic system and move to other organs and have it's just like planting. They go and seed themselves there and start growing. So for pancreatic cancer, majority of the time, before we diagnose it, it has gone to other organs, including the liver, and can go into the lungs and can go into the brain, and it starts growing there. So this is something which is very specific about cancers. They grow and detach themselves from the organ where they initially started.
So does it become deadly because they spread to other organs of the body, or I'm still trying to decode why this disease is so fatal. So the question, yes, go ahead, sir.
Yeah, so for pancreatic cancer, the reason why it's so fatal at times is because of the location. So 90% of pancreatic cancers are located at the head of the pancreas. And I've told you the pancreas is a very vital organ. It helps in digestion of food. Almost every food you eat, they produce enzymes that help in the digestion of food. The pancreas also produces hormones that do regulate our metabolism, meaning they regulate the amount of sugar you have in your body, the amount of fats. They do regulate all of these substances you eat. The pancreas at the head, once you have a tumor at the head of the pancreas, it blocks bile. Bile is produced also by the liver and stored in the gallbladder, and this helps us to digest food. So once these things cannot be done, people tend not to be able to eat food, tend to be lose weight, and also cancer in itself consumes a lot of energy in the body. The cells are ever growing, and they starve the normal cells, so they need all the nutrients. And once cancer metastases or goes to other organs in the body, what happens is if it goes to your lungs, it actually would cause your lungs to not function well. You would get recurrent pneumonias in the lungs. You would also get obstructions at the level of the lungs. If it goes to the liver, it's going to distort liver function. If it goes to the brain, it's going to cause a mass effect. If it goes to the kidneys, it's going to cause the kidney functions to go totally worse and your kidneys could fail. And generally in the body, it increases your amount of energy you're consuming, so you keep losing weight. And that is really how you die, because you're actually losing a lot of energy, and it can also be as a result of specific organs failing.
This is Chat Night Africa, and the topic on the show this week, pancreatic cancer. What exposes you to pancreatic cancer? If you have a pancreas, you can have pancreatic cancer. Now we're looking at the complications of pancreatic cancer. My guest on the show today is Dr. Kenneth Mfoma Mono. When we hear that somebody is diagnosed with pancreatic cancer, again, the first question that usually comes to mind is it what the person did or didn't do? I know you've elaborated on some of these aspects. And because of the fatal nature of the disease, the obvious other question is, could it have been prevented? Why is it that when I come for annual physicals in your office, or this is hypothetical, not you, but other doctors, why is it that doctors don't say, hey, look, let's check if you could be having pancreatic cancer? Why not?
Because pancreatic cancer, as I said earlier, we do not have very specific risk factors that are correlated to this cancer, and it's difficult to really diagnose it unless we do imaging. And it's not one of those cancers that screening for it actually makes public health sense and reduces mortality. So we do screen for pancreatic cancers in certain specific circumstances. When we have a strong family history of pancreatic cancer, you may see a gastroenterologist, and he will refer you to see a genetic counselor. And there are no real regulations at the moment, but certain doctors may get you to do a scan, which is an imaging of your stomach and the pelvis. They may get you to do an MRI also in order to see if there is a mass, and they could keep following it, but that is not a standard of care at the moment. But if someone comes with symptoms, let's say if you come to the hospital with pain, especially pain in the epigastric region, that's just above your stomach, pain radiating to your back, you also have jaundice, meaning your eyes are yellow, you have been losing weight and you don't know why you're losing weight, you also have some form of dark urine. Your urine is dark, your stool is light in color, you're having nausea, you're having some back pain, some diarrhea, some vomiting. These things could motivate doctors to actually screen for pancreatic cancer. But it doesn't make any public health sense to actually go ahead and screen like other cancers that we know they are completely related to the risk factors.
But then the question, doctor, is, and let me indicate to all those watching that you can dial the number 240-603-7367. If you have a phone today, you have a doctor, and the doctor is Dr. Ken Informa Mono. Why is it that people start seeing these symptoms when it's late? How is it that you cannot, or pancreatic cancer doesn't manifest itself until when? At what stage do you start seeing these symptoms you're mentioning?
Most of the time, you start seeing the symptoms when it's already stage 4 of the cancer, either stage 3 or stage 4, meaning the cancer is already blocking certain organs, especially the bile duct. And majority of the patients who come to us, they come to us because they have a yellow tint to their skin. We have a black skin. As black people, you may not notice it. No one around you could notice it, but your eyes could get yellow. But there are several other diseases that can cause your eye to get yellow. So this is one of the things that a lot of people notice. We could also see someone who is losing weight and doesn't know why he's losing weight, and comes because they're losing weight. When the cancer is very small, it doesn't really cause a lot of symptoms like other cancers, and we're not screening for it actively. Someone could be having epigastric pain for a long time and just decides to come to see a doctor, or pain radiating to the back, nausea, vomiting, problem digesting food. But the cancer itself needs to be big enough, especially for pancreatic cancer, to block organs that are near it in order for us to start having these symptoms. Most of the time, once you start losing weight from cancer, is because the cancer itself is getting big, and the metabolic activity of the cells are high, so they consume more energy and your other cells are starved.
I have a question coming in from Lambert Baum. Again, pick up your phone, you dial, you're coming live on the show. Lambert Baum says, is there something in Europe and the United States that exposes many to these cancers? Or is it like America's most able scientific president says the numbers of COVID-19 patients is skyrocketing because of too much testing?
So I would want to say, I told you initially the risk factors for pancreatic cancer, risk factors. I didn't say they cause pancreatic cancer. Smoking is one. And generally, we've had a lot of more smokers in the first world countries. The third world countries are adopting that now. Age is a big one. You need to live above 65. Majority of the time, Africans do not live above 65 years. Our our average our we do not live above that age group, so we don't even turn to see those kind of cancers. The second thing, we don't screen for them. We don't even have the technology to identify that you have the cancers. I would take, for example, my country of origin, Cameroon. How many CT scans do we have? How many patients can we actually scan their stomachs to know they died of pancreatic cancer? Usually people die, we don't know why they died. So we have not even reached the stage of diagnosing these diseases. That's why we don't see them. They could be existing, but we are not diagnosing them. That is very important. We do know people coming to die. We have never done an X-ray will not show you that you have pancreatic cancer. An ultrasound may be done, but a lot of people back in most African countries are not even trained to use the ultrasound very well, and it's not a good test to actually diagnose someone with pancreatic cancer. You need to have a CT scan, which is not the best. There is also an MRI, which is better, but we don't even have them in a lot of countries in Africa. You also need to do what we call an ERCP, which the gastroenterologists do, which can help you in diagnosing and treating some of the symptoms. All these technologies are not available in Africa, so we could have the illusion that we don't have these diseases. Just because we are not diagnosing them does not mean we don't have them. And in the US, blacks are more prone, and in Europe, to getting pancreatic cancer than whites. The number is not too different like in other diseases, but they are more common in blacks. So I just want to say we should not have this false sense of security.
When you
Oncology it's a very, very poor field, and a lot of people do not know how to treat oncological diseases back in Africa because that's not been our priority. Our priority has been in infectious diseases, which is good because you want to deal with basic things first, which you can cure.
What's the correlation between pancreatic cancer and being black?
So there is, I want to say, I don't want you to have, because of what I said, a false up thinking that blacks, the level of pancreatic cancer in blacks is just slightly greater than that in Caucasians and other groups of people. But that itself could be a confounder. So we need to look at it, maybe poor diet. We need to look at the data very well. But that's what we observed. But there is no real genetic explanation into that observation. Blacks in America have more metabolic symptoms, meaning they are more obese, they are more diabetic. And as I told you, having diabetes and chronic pancreatitis can be a risk factor. So looking at it from a public health standpoint, there could be confounders, meaning there are other factors, not really the blackness itself, that could be explaining this.
How does it happen that if your parents or family members had pancreatic cancer, you are at risk of having it? Is it genetically transferable if you want, or why should that be a reason why you should go examine yourself maybe frequently if you are exposed to or you are being or you're developing pancreatic cancer?
I said earlier, we have some genes we know about which increase your risk of getting pancreatic cancer. One of them is the BRCA1 and 2 genes, which increase your risk of getting pancreatic cancer. There are other genes, but they are being studied, but it's not really a one-to-one correlation like you could have in certain genes for breast cancer and other cancers that we have studied. But there are certain risk factors also just by having particular genes that could predispose you to develop pancreatic cancer if you have other injuries occurring in the pancreas. Injuries being like inflammation, if you're having diabetes, if you smoke, if you drink a lot of alcohol, if you have liver cirrhosis, meaning your liver has been destroyed by alcohol, and those things would increase your chances. But they are not really the cause.
Do you have, because I've visited offices of oncologists here in the United States, and sometimes you really see children, pediatric cancers patients. When it comes to pancreatic cancer, are there times children are exposed? You have young children who have pancreatic cancer. And the reason why I ask this question is they don't smoke, they don't drink alcohol. And if the answer is yes, how come you would have young children with pancreatic cancer if you do have cases like that?
Pancreatic cancer itself is very rare in children. That's the first thing I want to say. I'm not a pediatrician, but it's very rare in children. And each time we see rare things in people, we do have to write case reports. So pancreatic cancer, adenocarcinomas of the pancreas itself are very rare in children. There's another form of cancers called neuroendocrine cancers, which is something different, but it makes just about 5% of cancers of the pancreas, which you could see it in certain symptoms, certain syndromes, which are genetically inherited. But the majority of what we call pancreatic cancer, which is 90% of all the cancers, the one which is difficult to treat, very rare in children. It increases as you age. As I told you, anyone above 65, the more you live, the more you have a tendency to develop pancreatic cancer in itself. So that is really what this is all about.
This is Chat Night Africa, and it's reaching you from Washington, D.C. metropolitan area. My guest today is Dr. Kene Mfoma Mono. Doc, each time somebody has cancer, pancreatic cancer, breast cancer, the treatment we usually hear is chemotherapy. Is knowing how devastating, chemotherapy is. And I've seen people, family members whose relatives have died of cancer, whether breast cancer, prostate cancer, brain cancer. They say, you know what, chemo isn't what, if they have to relive it, chemo isn't what they would go for. Do they have a right to think this way? Do they have a reason to think this way?
So I would want to talk about the modalities of treatment. I'll come back to your questions for pancreatic cancer. So for pancreatic cancer in itself, once we get your diagnosis with pancreatic cancer early, the treatment we offer usually is surgery. There are several types of surgery we can do. There's a Whipple's a surgery that is done. It's named after the guy who actually developed this process. There is also a distal pancreatectomy, which you take away the distal part of the pancreas if the tissue is found at the end or at the tail of the pancreas. We can also do a total pancreatectomy. Now, in addition to that, we do chemotherapy. Chemotherapy is giving drugs which block the cell cycle development of any cell. So chemotherapy actually targets cells which are dividing very fast. That's how chemotherapy works. There are hundreds of different forms of chemotherapy with different side effects. Because they do affect cells that are dividing, they may also affect any cell in the body which is dividing rapidly. Example meaning usually you find people, their hairs fall off because the cells that produce hair divide very fast. They tend to develop nausea and vomiting because the cells in your gastrointestinal lining, your mouth right down to your stomach, they do divide very fast. So they affect those cells too. They also tend to affect the skin because the skin cells turn over very fast. So every cell in the body which is dividing very fast can be affected by chemotherapy. And chemotherapy has shown some very good response in certain cancers. In other cancers, it's been difficult, pancreatic cancer being one. And it also depends on how many chemotherapies you're getting. In pancreatic cancers, we do use a very harsh regimen. I don't want to go into it. At times, we call FOLFIRINOX. It's a combination of multiple cancer drugs that would help you actually treat the cancer. So pancreatic cancer in itself, because of the combination of the drugs we give, could turn around to have a lot of side effects. And before we start patients on treatment, we usually evaluate what we call their functional status, meaning how good can they tolerate therapy? Can they tolerate chemotherapy? We don't just give it to anyone. And based on that, we can decide to give you another regimen which is tolerable, better than giving you the regimen that could cause you to have certain side effects that are worse than others. And there are certain people who are not even candidates for chemotherapy. Someone who maybe comes in with a wheelchair, unable to get off the bed, those people will do very poorly. We tend to offer them what we call hospice or palliative care. Palliative care is different from hospice, but at times we offer hospice just to make you comfortable for the next 6 months in your life, take care of every symptom you're having. Palliation is making sure we take care of their pain, making sure we take care of any kind of symptom that makes their life uncomfortable. So chemotherapy, I don't want to put a blanket saying it's bad. That's what I offer. That's what I'm training to do. One of the things I use, not all. Chemotherapy is to help treat certain cancers, and we do cure certain cancers. So if you have a pancreatic cancer stage 1 and 2, we could do what you call neoadjuvant chemotherapy. We give you cancer in order to shrink, chemotherapy to shrink the cancer. Then we can ask the surgeons to operate it. And we can give you chemotherapy after the surgery, which we call adjuvant chemotherapy, in order to make sure that all the little metastases that could have happened, we are able to take care of them. And people get cured. Some people really get cured by this strategy. So chemotherapy in itself can have a lot of side effects, but overall, once you're a good candidate, if you have a good functional status, you're young, and it depends on the combination of chemotherapy you're getting. Not all combinations are the same.
At what stage, Dr. Muno, do you doctors say we are treating the cancer? The reason why I ask you this question is because when people bring their family members with cancers, especially pancreatic cancers, that's what we're talking about today, they meet you, the doctor, because they believe you are giving them medication or medicine that treats the disease. At what stage do you say you are treating the disease when you diagnose somebody with pancreatic cancer?
So when
And
we
if you're not
diagnose
treating the
someone,
disease, what the medication you are giving is for what?
so when we diagnose people with pancreatic cancer, I want to use a word. There are two different goals of care. Usually, we need to discuss the goals of care with the patient, what the patient wants. We need to tell them exactly by doing tests where the cancer is located. We need to tell them what the overall prognosis is for the particular cancer they have. And we need to ask them about their personal preferences based on the treatments that are available. Like for pancreatic cancer, we do have several modalities of treatment, meaning we can give you chemotherapy, we can give you radiation, we can also offer you surgery, and there are times we can offer certain targeted therapies, which do not work very well, but we can give it to certain patients, and we can offer you immunotherapy. And we can also offer you palliative care. So we talk about all these modalities. The first thing is to cure. I don't want to use the word treat. To cure a patient of pancreatic cancer,
What's the
usually we
difference between the
cure.
two?
The difference is when you're cured, meaning your disease goes away. Treatment can always be for palliative intent. Treatment can always be, we treat diabetic patients, but they don't get free of diabetes. Treatment can always be to make you live longer and live a normal life. Like we give treatment to HIV patients and they live a normal life, but they are not cured. So depends on the intention, and we work in collaboration with the patient so they tell us what they want. If you come in with a stage 1 pancreatic cancer or stage 2, which has not moved to the neighboring organs, and we feel that you can be cured, the surgeon is going to take you and propose to you surgery. There are people who decline surgery, such as people like the Steve Jobs had pancreatic cancer and used alternative form of medicine. The time he had it, he could have been cured. So you do what you call the Whipple's surgery, which is done in cases where you have the cancer at the head of the pancreas. Once they do that, they can send the patient back to us, the oncologists. We're going to give them some chemotherapy. And in the next 5 years, we evaluate if they are going to get cancer. We keep doing routine exams to see if the cancer comes back. If the cancer doesn't come back in 5 years, they are declared cured. But once you come in with stage 4 pancreatic cancer, the intention is not to cure you. We're never really going to cure you. There is metastasis everywhere. The intention is to give you chemotherapy, help you live longer, help you get few symptoms, do some palliation at the level of pain if you have pain. If you're having jaundice and having complications from it, we could get the gastroenterologist to put in a stent or the interventional radiologist to help us. At this stage, we're trying to prolong your life, make your life better so you can stay with your family and live a comfortable life. Once it's no more comfortable, we usually propose some form of palliation. If we are not able to help you with the treatments that are available, we propose some form of hospice care. What is hospice care? Hospice is in the US is defined by a law which states that if a doctor feels or the treating team feels that a patient is not going to survive in the next 6 months, they can offer them a holistic care where you have a nurse who is involved, you have a priest or whatever religion you are, we get them integrated. You have also a palliative care physician. These people are going to make your life comfortable. They are going to make sure you don't get treatment that can kill you. They are also going to make sure you live and die in an honorable manner and take care of your pain and other symptoms you're having. And this turns to actually increase life expectancy rather than giving them treatment when they don't need treatment, especially those who have a poor performance status.
Dr. Kenemfoma Mono on Chat Night. Why would somebody turn down surgery when it's possible that he could be treated by having the surgery performed on him? Is it likely going to cause impotence? Because that's usually what men worry about. I've seen people who have died of prostate cancer and they turned down surgery when surgery could have helped because probably they had a young wife and they were worried that if they had surgery, the surgery could incapacitate them. In other words, get them become impotent. Why would somebody turn down surgery in times when they have pancreatic cancer?
Well, the good thing is, in the US, you have the choice to decide if you want treatment or not. What the surgeons usually do, I'm not a surgeon, but what they do, we do holistic management of patients with pancreatic cancer. We always tell them what the risks and benefits are. There are always risks if you're getting into any major form of surgery. So we usually tell the patients what the risk. There's a risk of dying even during the procedure. Others could be afraid that they're not going to make it. Others have fears of being intubated in the first place in order for the surgery to be done. Others just feel that they don't want any intervention to be done on them. Others believe in other forms of treatment and may not want it. So this is usually personal, and there are several reasons why people could opt out of surgery, but we try to tell them what the advantages are. For pancreatic cancer, you would want the patient to get surgery in a center where they do the surgery often because it's a complicated surgery and you need a surgeon who has been doing this surgery for a long time and who has a certain number of cases they do. So we send them to patients, to surgeons who have been doing this, and the survival rate is pretty high. The death rate in areas like Mayo Clinic and UCLA, Mount Sinai, those are areas where even in John Hopkins, their death rate from Whipple surgery is very low. So there is a chance for you being cured once you have pancreatic cancer, which is stage 1, and or stage 2 that has not actually gone to neighboring organs or has not actually touched the mesenteric artery. That's an artery which you have at the level of your stomach. Let me put it that way. I don't want to be using a lot of terms.
Let me remind our audience that they can dial the number 240-603-7367, or if you're overseas, you can call via WhatsApp 001-240-603-7367. What are the chances of pancreatic cancer recurring when the patient has been treated or cured?
So this is a very
I'm
tricky
not using the
question.
words as you medical doctors. You probably want to call me Dr. Divine. No, I no, but anyway, just on a lighter note, how therefore, so yeah, before I get to the next question, please answer this.
So it all depends on what stage the cancer was at. That's why we keep monitoring patients who have been so-called cured, because curative intent is usually meant for patients who have stage 1 and stage 2 of the disease. I said stage 1 is when the cancer, it says, is less than 2 centimeters and has not affected major organs. Stage 2 is also when it's greater than 2 centimeters but has not affected neighboring tissue. If the surgeon can take this whole cancer out and create what you call negative margins, meaning the tissue around where the surgeon took the cancer out are not positive for cancer, then you can have a curative intent. Now, reoccurrence depends on multiple factors. If this guy goes back and continues drinking, if he goes back and continues having poor nutrition, eating a lot of red meat, and also has a family history of pancreatic cancer, he could have a reoccurrence. If not, he has the same chances like anyone else of getting cancer, which is 1% in a year, in your lifetime. So for pancreatic cancer, that's really what it depends. But if you have stage 4 disease or stage 3 disease, and we give you chemotherapy, it happens rarely and it disappears totally. Majority of the time, once we stop, there are microcytes, there are certain small cells that are still cancerous that could grow and reoccupy the whole area. That's why you need to be monitored by an oncologist continuously with what you call a PET scan, which is something we use, is very not found in all countries. We use that in order to monitor patients to see if they have had a reoccurrence for cancers. So usually these patients are monitored throughout their whole life.
Dr. Former, this broadcast is aired across Africa, and as Africans, you can't take us away from alternative medicine. Have you heard situations? I know probably it's going to be difficult for you, a Western trained doctor. Let's see somebody on the line. Chat Night Africa. Hello. 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 If you are in the United States, your call doesn't need to be a WhatsApp call, please. You can just dial the number. Hello.
Yeah, good evening.
Yes, if you're calling from the United States, please, we might want to drop off and just dial the number directly, okay? Okay. All right. Yes, sir. While we wait for the caller, alternative medicine and Africans, just inseparable. Have you heard situations that somebody says, their relative got cured of pancreatic cancer because maybe they mixed that concoction and then drank? I don't know. Have you heard things like that?
Well, I have heard for other cancers, but for pancreatic cancer, I didn't know because, as I told you, you need a lot of technology itself to diagnose that someone has pancreatic cancer. So I think it's underdiagnosed in our country. In Africa as a whole, there are some African countries that are more developed than others, like South Africa. You get up in the north of Africa, you have others that have better technology. But from where I'm from, the diagnosis itself of pancreatic cancer is rare. I've not heard about anyone who has been cured out of traditional medicine or African traditional medicine. But it's important to note that African traditional medicine is based on herbal plants, which a lot of cancer drugs are also taken from herbs. They are not magical drugs around. They are cancer drugs that got their origin from plants, a lot of them. And that's how we knew that they work. So people could be combining these particular plants in order to help treat certain cancers, but African traditional medicine is not all that bad. I am a good advocate of African traditional medicine, especially when we can prove it. We need to put it in the same standard like any other form of medicine we're doing. We should not use our emotions and try to get emotional about it. If we think something is working, let's prove it and show that it's working. And I'm one of those who believe that we can teach the Western world some one or two things new concerning any kind of disease out there.
If you, Dr. Former, got diagnosed with pancreatic cancers or pancreatic cancer, is there some foods or are there some foods, African foods, that you think you should eat?
I don't think there's some specific food I would call African food that I have to eat. I don't think so. What I think I would do is I would need to get good nutrition. You would need to talk to a nutritionist, get to eat food which is rich in plant protein, and not a lot of red meat, which is actually one of the risk factors, not a very high risk factor, but it contributes. Make sure you have a balanced diet. You eat a lot of food which is rich in calories because having pancreatic cancer itself and other cancers, you consume a lot of calories. So eating well, making sure that you do not eat food which can irritate your stomach is very important. Things which are extremely high in fat, so you overall just need to eat well. And every culture has good food in its.
I have noticed that when you go for medical checkup and you're told to come back, or you're told that the doctor's nurse will call you after a few days, and usually that's to say, well, prescription. And then when you are being called to the doctor's office, usually the news is not good. It must be very tough for you doctors to disclose to somebody that unfortunately they're diagnosed with pancreatic cancer. Now, we in Europe and the United States, when a loved one dies, maybe your mom or your dad, they call you and start telling you how they're sick. And then they introduce the subject gradually. They slide you into that situation gradually. How is it like? What do you doctors tell people whose diagnoses are cancerous? In this case, they have pancreatic cancer. How do you break the news?
As you said, you already actually made mention of several techniques we can use. We usually want you to come into the office because we can't give a news like that over the phone or through a third party that we don't know you have support. Most of our patients who are having cancers, those who are already diagnosed, we encourage them to come in with a support group, to create a support group, to get their families to know that they have it. So most of the time, we'd invite them to come with some loved one if they do want to. We are going to try as much as possible to be quiet most of the time and let the patient talk. You want to know what the patient knows already. You want to break the news and see how the patient reacts, because based on that, you may get other uh, people that could help this patient, including social workers, case managers, including psychiatric doctors, including other things that we offer in the cancer center. It needs to be a holistic approach. So you want to listen to this guy and see how he reacts to this news. And two, based on the stage of the cancer, how widespread the cancer is, we want to propose to them the available treatment and tell them what the prognosis are, meaning what are the chances of surviving if you're treated with the specific treatments that are available. So we want to give them all this information step by step, taking into consideration their reactions. It's very important to do this so that you are able to better understand your patient. And also, there are people who opt out of treatment in itself. There are people who already knew somehow that they could have, we have told them before they have a mass. But telling someone they have pancreatic cancer, I'll use a statement we use in oncology a lot. We say, no tissue, no issue. Meaning, if we have not taken the tissue and sent to a pathologist to tell us it's a cancer, then we don't tell the patient they have a cancer because it could come out to be something else. So we want to be sure it's a cancer. That's when we tell them they do have a cancer. But before that, we build the anxiety towards that. We try to reduce the anxiety. We know it's building up. And we try to, once we are kind of almost sure, tell them they could have cancer.
When I hear they could have cancer, you saying that they have cancer.
I will tell you a story. I'll tell you a story which I had a patient recently who had a mass in the lungs, and he was a smoker. So that's a risk factor. He had a family history of cancer too, and we thought for a while that he had lung cancer. So he came in with this mass. We saw it incidentally. We did a biopsy, meaning we took out the tissue. We didn't tell him he had cancer, but we knew it was going to be cancer. But it came out to be an infection, an aspergillosis, which we did a second biopsy of everything he had. He didn't have cancer. So
I can tell you he went home that day and drank a cold beer.
So there are situations truly that you need to actually know that the patient has cancer. And as I told you, a lot of people think when you say someone has cancer of the lungs, is the same. Cancer of the lungs, there are several kinds of cancer of the lungs based on the tissue that is causing the cancer. So you could have a small cell cancer of the lungs, which prognosis are very bad, meaning the prognosis is not good. You could have a non-small cell cancer of the lungs. You could have an adenocarcinoma. There are several other cancers you could have. So we want to get tissue so we can be able to treat these patients.
Doctor, we've been talking about pancreatic cancer on the show today. Anything you think we left out, which you think people should know about pancreatic cancer?
Well, what I want to say is that pancreatic cancer, the incidence, meaning the number of people having this diagnosis, is increasing. As years go by, we're trying to understand why. Maybe because we're trying to treat other cancers, like cervical cancer has been totally almost eradicated based on giving the human papilloma virus vaccine to young girls and boys. And we have cancers like colon cancers. The gastroenterologists are good at screening for these cancers and taking care of precancerous lesions before they do occur. The world as a whole has stopped smoking. The level of people who smoke have reduced. So the number of lung cancer, the incidence, the number of new cases of lung cancer is actually reducing worldwide. And we do know how to manage breast cancer better. And we also know how to manage prostate cancer better. So pancreatic cancer is actually climbing the list. And in the US, it's like the fourth cause of death. Very soon, it may be the third among all cancers. It's one of those cancers that is a lot of research going on. And we are trying other treatment modalities, which we do use in cancers such as melanoma, lung cancer. We call them immunotherapy. We use your immune system in order to cure your cancer. Usually those treatments are pretty benign. They have their own side effects, but majority of those taking it don't even know they're taking cancer drugs.
But then if you're going to use some of this immune system, or I'm assuming that when somebody has pancreatic cancer, it breaks down the person's immune system. How do you do that then? How does the immune system become effective in fighting the cancer when the cancer would have broken down the person's immune system?
So what happens, I want to digress a bit. When you have cancers in your body is very complex. It's like one of the best I always want to attribute it to the military. Your body moves around, you have your immune system moves around looking for cells. We do create a lot of cancer cells. Cancer cells are cells that just start replicating without respecting the regulations of the body controlling cells. Your immune system moves around. There is what you call your your T cells, which are specific white blood cells that move around, or natural killer cells, and they find these cancer cells and kill them. Cancers have learned to be wise. They have learned to disguise themselves. So they don't actually, some of them don't express cancer genes. So they don't express markers to show that they are cancer cells, and they disguise themselves from the immune system. What we do is a huge field in medicine where there's a lot of development going on. What we do is we try to mask this disguise they're having. And the immune system is like, wow, now I know you're a cancer cell. And they destroy them. So we're able to do that actually right now in a lot of cancers. You could have a stage 4 lung cancer, non-small cell lung cancer. We give you some immunotherapy and you can live as long as, if you're lucky, someone who doesn't have cancer. So we're able to disguise this particular cancer cells that turn to disguise themselves. We're able to unmask them so the immune system can actually know that they are cancer cells and treat them. And specific cancers affect the immune system. Not all cancers affect the immune system. Cancers affect specific organs. Cancers that do affect the immune system, they are lymphomas, leukemias, because they are actually cancers of the immune system. But in the long run, when these cancers go everywhere, you die of some form of anorexia, you get thin, your metabolism is so high that your body cannot sustain it. So those are the things that actually do kill you. But we're trying to see if we can harness the immune system. There's a lot of new good things happening, which may not reach Africa soon. There's what we call CAR T cells. They are cells that we can actually train the immune system to kill cancer cells. We use targeted therapies, meaning we do know how the body regulates growth. So we're able to stop certain cells from growing. And once we stop them from growing, they die. They are not chemotherapy, but they are targeted therapies, there are immunotherapies, there are CAR T cells. There are so many modalities that are under research that we use for cancers.
If and that raises hope. And so if somebody had this terrible diagnosis of pancreatic cancer, do they therefore say, I want the kind of therapy A or therapy B? Or how do you doctors get to choose?
We start off the news this.
How do you doctors get to
We
choose?
start off the news this week.
Sorry. How do you doctors get to choose which regiment, or maybe not regiment, what therapy, what treatment to give patient A and not patient B when both of them have pancreatic cancer?
So for every cancer, we do have data, which is research. And in medicine, there is a pyramid of evidence, meaning we have clinical trials that have been done that tell us what treatment treats this particular cancer. So for pancreatic cancer, we do have evidence on the combination of chemotherapy that is going to help these patients. There is evidence out there, and we propose to them evidence-based medicine. We propose to them what has worked. So for pancreatic cancer, I'm going to summarize it. What works is surgery works if it's early. Surgery does not work if it's late. So we don't propose to patients who have metastatic cancer surgery. Also, we do propose to them radiation. It helps when the cancer is located regionally. We propose that to them. Chemotherapy helps when you have a good functional status, meaning you're young, you're vibrant, you can be elderly but vibrant and able to walk around. We propose you chemotherapy. There are times when we do propose certain palliation, which we could have patients who are jaundice, who are dying of an infection of the gallbladder because the cancer has blocked the gallbladder. We could put a stent in order to open up that area. Is done by specific gastroenterologist or interventional radiologist, and the symptoms go away. If you have pain, we could provide you with pain medications. We can do what you call a celiac block. We can block the nerves that actually cause you to have that pain by using alcohol or by cutting them off, and you actually don't have pain anymore. So the modality of treatment really depends on who is in front of you, what kind of symptoms they have, what is the stage of the cancer. But we propose to everyone what the modalities that have been tested, that have been proven, And in oncology, we do a lot of research compared to other fields. There is also one other thing we propose to them. There are times you come to us and you are not a candidate for any clinical treatment that has been proven. We can propose to you that there is a clinical trial going on in a specific center, where those trials are usually done to test new drugs. And people opt to get to do those trials. We have to tell you what the side effects are. And at times, if you don't get into those trials, you may die because we don't have a specific treatment for your cancer. So that's how research is done also in medicine, but the people have to accept. Immunotherapy and targeted therapies do not really work very well right now in pancreatic cancer. So we usually don't propose that to them. We propose that to them when they have failed chemotherapy. We do what you call a next generation gene sequencing. We sequence the genes of the cancer and we try to get targets that we use for other cancers in order to treat them. So that is usually the last resort. But in the next 2-3 years, a lot of things will come out about pancreatic cancer. Each time being human is being very ingenious. The human race is very ingenious. They are putting their minds together, and I think good things will come out.
You are watching Chat Night Africa. Dr. Mono, your last word before we go. And of course, I'm just getting indications on the line from Nigeria that Chat Night Africa's chief correspondent in Africa is on the line from Nigeria with Africa This Week in the News. Yes, but before we get to that report from Nigeria, your last word, sir.
So I want to know from you, no one asked questions. There were no questions that were raised.
It should be that you answered all the things you said, answered all their questions.
Okay, what I want to say is our oncology is one of those fields where it's not well developed in Africa overall. And the drugs are now extremely very expensive. The level of care we need is really expensive. And I don't think at the moment it may not be a priority in Africa because we still have infectious diseases that are killing a lot of people. We do have also a double pandemic with chronic heart conditions that are killing people, but we need to improve on our level of oncology, our level of diagnosing cancers and treating them in the future. And pancreatic cancer, in talking specifically about pancreatic cancer, there are some risk factors, but they are not really very correlated with pancreatic cancer as much as we want to. There is a lot we don't know about pancreatic cancer. If I want to advise you on what to do if you have pancreatic cancer or you want to prevent yourself from getting pancreatic cancer, you should stop smoking, which is going to help you prevent you from getting lung cancer. Also prevent you from getting head and neck cancers, prevent you from getting cancer of the esophagus. If you also renal cancer, you should also improve on your diet, which could help you reduce the amount of red meat you consume, could help. As I say, it's just a correlation. Also, you could lose weight. Losing weight is always good. Exercise is very good for everyone. So those are the things that can actually help. Also, if you have a family history of pancreatic cancer, you could also tell your doctor about it so that you get screened. There are no clear modalities now on how to screen patients and when to screen them, especially here in the US, but you should need to tell someone so we get to monitor you. If you have something that develops, it's caught fast and taken good care of. So I think, Divine, that is my advice to, if we're talking about some other cancer, then I'll be able to say more, especially lung and other things. So thank you.
Well, we will come back to lung cancer at some point in time. Thank you so much, Dr. Kenen Former Mono. You've been just, each time we come knocking at the door, you are showing up to share your knowledge with the audience of Chat Night Africa. This broadcast is aired across Africa to thousands and thousands of people. Doc, once again, thank you so much, my dear friend. Give my regards to your loving wife.
Okay, thank you. And I'm sorry about the quality of my pictures today. So we'll work on that next time.
Thank you, sir. Ladies and gentlemen, as I said earlier, Chat Night Africa's chief Africa's correspondent in Nigeria, is on the line with Africa This Week in the News. Here is Jerry Johnny connecting from Nigeria.
We start off the news this week in Uganda, where prisoners jailed in that country overpowered their guards, and 219 of them escaped with at least 15 guns, but 2 were killed after security forces launched an operation to recapture them. A military spokeswoman said on Thursday the inmates escaped late on Wednesday from a jail in Karamoja, a remote semi-arid northeastern region, said the spokeswoman, Brigadier Flavia Biekwazo. Before fleeing, they broke into the prison armory and stole 15 AK-47 rifles, 20 magazines, and other ammunition. And in Somalia, the country's president has appointed a new prime minister, stating that the new appointee, Mr. Rubble, was selected on the basis of his knowledge, experience, and ability to move forward with state-building efforts and the development of national plans. Mr. Rubble is a relative newcomer to Somali's politics. The decision will now go to Parliament for approval. In Ghana, the presidential candidate for the National Democratic Congress, NDC, John Dramani Mahama, has joined many calling for the law that bans importation of salvage cars to be expunged. According to the NDC flag bearer, a sudden decision by the government to suspend the implementation of the law on November 1st, 2020 is a political gimmick. Police in Uganda have launched an investigation into the cause of the fire outbreak that ravaged the main building of the Uganda's Makerere University. According to police, the fire, which broke out in the wee hours of Sunday, is believed to have started from the top of the roof, spreading to floors that house both records and finance departments. Beside the office of Professor Nagwangwe and other administrative offices, the building holds student records. The basement is full of archives, files spanning the whole history of the institution. In South Africa, an assortment of weapons was found in one of the unoccupied doctors' quarters at Chris Hani Baragwanath Academic Hospital in the early hours of Sunday. The health department said it consisted of 47 bullets, 3 9mm handguns, 2 pepper sprays, 2 handcuffs, 1 SAPS reflector vest, and a police car. They were discovered at the vacant quarters, which is due to be renovated by security officers during a routine patrol. The matter has been handed over to the Dipluf police, who have since opened a case and are conducting further investigations. From Uyo, Nigeria, my name is Jerry Johnny, reporting for Chat Night Africa Live. Thank you so much for listening.
And that's our reporter, our chief Africa's Chat Night reporter in Nigeria, Jerry Johnny, reporting. Jerry Johnny files in weekly reports from Nigeria each time we are on Chat Night Africa. Thank you so much, Jerry Johnny. Please give my regards, our love from the fountains of Chat Night Africa to every person watching this broadcast in Nigeria. We love you. We have a lot of viewers and foot soldiers in that beautiful country of Africa called Nigeria. Ladies and gentlemen, that's how we end this week's edition of Chat Night Africa. Chat Night Africa from Washington, D.C. metropolitan area. Thank you, Dr. Kenneth Mamuno, for coming on to take questions from Chat Night Africa. Chat Night Africa production advisor, Dr. B. Tatsong Famunda. Broadcast director, Mombalingwa. This is Chat Night, the power of Chat Night. social media platforms manager and video editor, Sir Roger Fool in Lagos, Nigeria. This is Chat Night. Studio Director Beatrice Famune. Production assistants Emmanuel Indi, John Tanto, and Lord Benson at Funch Street, Bamenda. Chat Night Africa is compiled and presented by Divine Chamukong with special support from Daniel Eno in Maryland. Until when we meet again for yet another jaunty broadcast. Merci à tout le monde. Thank you to everybody. It's been wonderful having you out there as our audience. Please be the flag bearers, the foot soldiers for Chat Night Africa where you are. Thank you.
We're gonna dance. We're gonna dance. I'm coming back. I'm coming back. I'm coming to get down. I'm coming to dance. We're gonna dance.